What I'm about to tell you is going to challenge one of the most repeated health beliefs in America. And when I reveal why the so-called perfect blood pressure number can actually become dangerous for some older adults, you're going to understand why thousands of seniors spend years chasing a target that was never meant to be chased blindly. I'm Dr. Aliza Wright, and if you are over 60, over 70, or caring for someone who is, this conversation may change the way you look at every blood pressure reading from this day forward. Because the biggest myth is not that blood pressure matters. It absolutely matters. The myth is that one magical number fits every older body, every older artery, every older brain, and every older heart. Before we begin, please subscribe to my channel for clear senior health advice that protects your heart, brain, and independence. And now let me tell you why this matters so much. Somewhere right now, a senior is staring at a reading of 134 over 72 and feeling like they've failed. Somewhere else, another older adult is proudly celebrating a reading of 108 over 58 while ignoring the dizziness, the fatigue, the near fall in the hallway, and the fogginess that started after a medication increase. Both people may be misunderstanding what their numbers really mean. And when blood pressure is misunderstood, seniors do something heartbreaking. They either panic over numbers that may be acceptable for them, or they feel reassured by numbers that may be too low for their body to tolerate safely. Let me say the myth out loud so we can expose it completely. The myth is this: the best blood pressure for every older adult is exactly 120 over 80. That sounds neat. It sounds clean. It sounds medically official. It sounds like the kind of number you print on a refrigerator magnet and follow for the rest of your life. But human physiology is not a refrigerator magnet. Aging changes arteries. Aging changes medication tolerance. Aging changes how quickly blood pressure drops when you stand up, how stiff blood vessels become, how kidneys respond, how the brain is perfused, how the heart muscle fills between beats. And if you ignore those realities and chase one single number without context, you can end up treating the number while harming the person. Let me tell you about Eleanor, because her story reveals this better than any chart ever could. Eleanor was 79, fiercely independent, still drove herself to church, still gardened, still cooked Sunday dinners for her family. Her doctor had told her years earlier that healthy blood pressure was 120 over 80, so Eleanor made that number her mission. Every reading above it felt like danger. Every reading below it felt like victory. Then 1 month, her medications were adjusted, and suddenly she was getting readings around 116 over 62, sometimes 112 over 60. She was thrilled. She thought she had finally won. But within 2 weeks, she started feeling lightheaded when she stood up, weak in the shower, and strangely exhausted by noon. One morning, she blacked out for a second near the kitchen counter. Eleanor thought the problem was age. Her daughter thought the problem was dehydration. But the real problem was that everyone was celebrating the number instead of listening to the body. When I reviewed her case, what struck me was not that her pressure was catastrophically low on paper. It was that the number looked beautiful while her symptoms looked dangerous. That is the trap. For many older adults, the right question is not, am I at 120 over 80? The right question is my blood pressure low enough to protect my heart and brain, but not so low that it steals my balance, my strength, my kidney function, or my independence? Eleanor did not need a prettier number. She needed a safer one. After careful adjustment, she stabilized at readings closer to 128 to 134 systolic, and her dizziness disappeared. Now here is the first truth that almost no one explains clearly. 120 over 80 is a category, not a commandment. It is a reference point, not a universal prescription for every older adult in every circumstance. When people hear that a normal blood pressure reading is under 120 over 80, they assume anything above that is automatically failure, and anything below it is automatically success. That is not how good medicine works. Good medicine asks what your average home readings look like, whether you have symptoms, whether you are frail or robust, whether you have kidney disease, diabetes, coronary artery disease, memory issues, falls, or medication side effects, and whether your pressure drops when you stand. In other words, doctors are supposed to treat you, not worship a number. And here is the second truth, and this one becomes more important with age. For older adults, the top number, the systolic pressure, often tells us more than the bottom number about cardiovascular risk. Why? Because as arteries stiffen with age, systolic pressure tends to rise. That means the blood pressure issue many seniors battle is not always a dramatic bottom number. It is often a creeping top number that slowly climbs with time, while people still say, well, I feel fine. This is one reason older adults can have what looks like a decent diastolic number, yet still carry a higher risk from the systolic side. And it's also why two seniors with the exact same reading may need completely different decisions depending on symptoms, trends, and the rest of the medical picture. Now let's talk about the third truth, because this is where the myth becomes emotionally manipulative. Single readings are seductive. They make you feel as if health can be captured in one moment. One number, one glance, one verdict. But blood pressure does not behave like that. It changes with sleep, meals, stress, pain, temperature, activity, hydration, medication timing, and even whether you had to rush to answer the phone before you sat down. That means the best blood pressure for an older adult is not judged by one dramatic reading at the doctor's office or one anxious reading at the kitchen table. It is judged by patterns, averages, and tolerance. Seniors get into trouble when they chase the prettiest isolated reading instead of the most reliable overall pattern. Let me show you what I mean through Gloria. Gloria was 76, warm, lively, and absolutely terrified of doctor visits. Every time she sat in a clinic chair, her pressure shot to 162/88 or 168/90. Her family was certain she needed more medication. She was certain she was on the edge of a stroke. But when we had her measure properly at home for 2 weeks, resting quietly, morning and evening, the truth looked completely different. Her home average was 128/74. Not perfect every single time, but steady and reassuring. If we had intensified her treatment based only on those office numbers, we could have pushed her too low at home. Instead, we recognized white coat effect, protected her from overtreatment, and spared her a cascade of side effects she never needed. This is why I want every senior watching to understand something deeply. A number without context can be a lie, even when the machine is accurate. If your home average is controlled and you feel well, that tells a different story than one office reading that spikes because you're anxious. If your seated pressure looks great but you nearly pass out when you stand, that tells a different story too. The myth of 120/80 seduces people because it feels simple. But simplicity can be dangerous when it erases context. Older bodies deserve context. Older adults deserve medicine that recognizes complexity. You are not a spreadsheet. You are a human being with a nervous system, circulation, medications, and lived experience. And your blood pressure target must respect all of that. Now we come to the fourth truth, and this is where many seniors finally realize why chasing lower and lower numbers can backfire. The standing blood pressure matters. I cannot emphasize this enough. Some older adults look fine sitting down and become underperfused the moment they rise. Let me tell you about James, 81, who proudly told everyone his blood pressure was finally ideal. His seated readings were often 118/66. He was delighted. His family was delighted. But James had started grabbing furniture when he got out of bed, pausing after standing, and feeling a wave of weakness in the grocery store. He thought he was just getting old. What he was actually experiencing was a significant blood pressure drop on standing, the kind that turns a good-looking seated number into a fall risk. Now here is the fifth truth, and it might be the one that surprises you most. Diastolic pressure, the bottom number, can become too low in a way that looks harmless until symptoms begin. Many people are so obsessed with lowering the top number that they ignore what happens to the bottom number in the process. But the heart, especially the older heart, receives its own blood supply during relaxation, during that diastolic phase between beats. So when the bottom number gets pushed too low in some older adults, especially those with stiff arteries or coronary disease, problems can emerge. Not always, not in everyone, but enough that smart clinicians pay attention. This is why the best blood pressure for seniors is not simply the lower the better. That slogan has harmed more people than it has helped. Let me tell you about Carol. Carol was 78 and had been doing everything right. She walked daily, took her medications faithfully, kept her appointments, ate carefully, and never missed a blood pressure log. Over time, her regimen was intensified because everyone wanted to bring her systolic number down aggressively. Eventually, she started getting readings like 121 over 58, 118 over 56, 116 over 55. On paper, some people called that excellent. In real life, Carol felt drained. She developed more fatigue during walks, occasional chest tightness, and a strange sense of weakness in the late afternoon. The issue was not that her blood pressure had entered some dramatic emergency zone. The issue was that her circulation and symptoms were no longer in harmony. Again, the number looked neat, while the body told a very different story. This is where medicine becomes art, as well as science. Because no doctor should look at Carol's symptoms and say, "Ignore how you feel, the number looks beautiful." That is lazy medicine. That is number worship. The better question is whether pressure lowering is reducing risk while preserving function. If not, then something has to be reconsidered. Maybe the dosage, maybe the timing, maybe the combination, maybe the true target for that specific older adult. And this is exactly why the 120 over 80 myth is so stubborn and so destructive. It teaches people that health is obedience to a number, but the truth is more mature than that. Health is controlled pressure, yes, but with preserved cognition, balance, kidney function, energy, and freedom from avoidable side effects. Now let's get even deeper, because this next part separates generic health advice from real older adult medicine. Not every 70-year-old is the same. Not every 80-year-old is the same. And certainly not every person over 65 should be pushed toward the same destination in the same way. A strong, active, community-dwelling 68-year-old who exercises, thinks clearly, and tolerates treatment well may benefit from a lower target than a frail 89-year-old with multiple medications, recurrent falls, kidney disease, and memory problems. Age matters, but function matters even more. Frailty matters, cognitive status matters, standing symptoms matter, life expectancy matters, coexisting illness matters. If anyone gives you one blood pressure target without considering those things, they are not giving you individualized care. They are giving you a slogan. Let me tell you about Harold and Martha, a married couple who accidentally proved this point in the clearest possible way. Harold was 83, mentally sharp, physically active, walked every morning, managed his finances, cooked twice a week, and tolerated treatment extremely well. Martha was 84, brilliant and resilient, but more fragile physically, with balance issues, chronic kidney disease, and 2 falls in the previous year. Their children assumed they should have the same blood pressure goal because they were almost the same age. But medically, they were completely different cases. Harold could safely pursue tighter control with close monitoring because he tolerated it and remained steady. Martha needed a far more cautious approach because the cost of pushing her too low was not theoretical. It was a fractured hip, a hospital stay, and the loss of independence. This is the 6th truth. For many healthy older adults living independently, lower systolic targets can reduce the risk of stroke, heart failure, and major cardiovascular events when treatment is done carefully. That part is real. That part matters. I do not want seniors hearing this video and concluding that high blood pressure no longer matters or that treatment goals should be ignored. Absolutely not. Uncontrolled hypertension remains one of the great silent destroyers of the brain, heart, kidneys, and blood vessels. The point is not that lower pressure is bad. The point is that lower pressure has to be pursued intelligently. Many independent seniors can benefit from getting under 130 systolic if they tolerate it. But if they tolerate it is not a footnote. It is the entire clinical decision. And that brings us to the 7th truth, the one I wish every senior would write down. The best blood pressure for an older adult is the lowest pressure that meaningfully reduces long-term risk without causing short-term harm. I want you to hear those words again in your mind. The lowest pressure that reduces long-term risk without causing short-term harm, not the prettiest number, not the number your neighbor brags about, not the number someone on television declared perfect for everyone. The safest target is the one that protects your future without damaging your present. If treatment saves your heart but takes your balance, something is wrong. If treatment lowers your risk but wipes out your energy and makes you afraid to stand, something is wrong. This is why thoughtful doctors individualize care instead of chanting 120/80 like a ritual. Now let me show you how this myth hurts seniors emotionally, because the damage is not only physical, it creates shame. Seniors start feeling that a perfectly respectable reading is somehow a personal failure because it isn't perfect. They take a reading of 131/76 and feel guilt. They see 128/74 and feel only temporary relief. They see 118/60 and feel triumphant, even if they're lightheaded. That is psychological conditioning, not health education. And it's dangerous because shame changes behavior. It pushes people to overmeasure, overreact, self-adjust medication, panic over routine variation, and ignore symptoms if the number appears attractive enough. The myth doesn't just misinform, it distorts judgment. It teaches seniors to trust an abstraction more than they trust the signals coming from their own bodies. Let me tell you about Denise. Denise was 74 and checked her blood pressure 6 times a day: morning, mid-morning, lunch, afternoon, evening, bedtime. Why? Because she had convinced herself that any value above 120/80 meant she was in danger. If she saw 137/78, she'd sit down again and recheck. If the second reading was 133/76, she'd feel only partial relief. If it stayed high, she'd spiral. Some days, she took extra medication without approval because she was so frightened by the top number. By the time she came to see me, her real problem was no longer simple hypertension. It was anxiety layered onto hypertension, driven by a myth that had stripped all nuance from what blood pressure management is supposed to be. We had to treat the fear as much as the pressure. What finally helped Denise was learning a new question. Not, how can I force this reading to be 120/80? But, what does my average tell us, and how do I feel at that level? We narrowed her measurement schedule. We emphasized proper technique. We reviewed which symptoms mattered and which small fluctuations did not. We talked about home averages instead of isolated spikes. And slowly, her relationship with blood pressure changed. She stopped seeing every number as a moral verdict. She started seeing it as information. That shift matters more than most people realize, because once a senior understands that the goal is safe control, not perfection theater, the entire emotional burden lifts. Blood pressure management becomes calmer, smarter, and much more effective. Fear shrinks. Clarity returns. Adherence improves. Quality of life improves too. Now I need to tell you about a number that often matters more than people think. Your home average, not your best reading, not your worst reading. Your average measured properly at consistent times under restful conditions. If you want to know whether your blood pressure is truly controlled, that average tells the story far better than random emotional snapshots. And for older adults especially, that average must be interpreted alongside symptoms, medication side effects, and standing measurements when needed. This is what separates safe management from number chasing. If your average is reasonable and you feel steady, that is powerful information. If your average looks good, but you feel weak, dizzy, or foggy, that is also powerful information. Do you see the pattern? The right target is always a partnership between data and function. And since we're exposing myths, let me destroy another one, hiding inside the first. Many seniors think if their bottom number is normal, the top number doesn't matter much. That is simply not true after midlife. As arteries stiffen, systolic pressure often becomes the bigger warning sign. This is why someone can have a reading like 148/68 and say, my bottom number is fine, so I'm okay. Not necessarily. That widened gap can reflect stiffer arteries and rising cardiovascular risk, even when the diastolic number looks respectable. Older adults cannot afford to ignore the top number, but they also cannot afford to push treatment so hard that the bottom number sinks too far and symptoms begin. That balancing act is the heart of good hypertension care in seniors. Balance, not obsession, is the real principle. Let me tell you about Frank, because his story brings urgency into focus. Frank was 77 and had spent weeks thrilled with his excellent readings after a medication change. The top number came down beautifully. Everyone clapped, but Frank started feeling unsteady in the shower. Then one morning his legs felt weak getting out of bed, and by afternoon he had almost no energy. He delayed calling because he thought the numbers proved everything was fine. He assumed the symptoms must be unrelated. That assumption is exactly what the 120/80 myth teaches people to do. It teaches them to distrust symptoms when the monitor looks attractive. Frank finally came in, and sure enough, his regimen had become too much for his body. Once adjusted, his pressure remained controlled, but his strength and confidence returned. Never let the number silence the body. And now I want to tell you what smart blood pressure management for seniors actually sounds like in real life. It sounds like this. Your average is improving, but how do you feel when you stand? It sounds like, your systolic pressure is still a bit high. Let's lower it carefully and recheck kidney function. It sounds like, you're independent and tolerating treatment well, so we may be able to aim lower. It sounds like, you've had falls and dizziness, so we need to be careful not to overdo this. Notice how different that is from, everybody should be 120/80. Real medicine asks follow-up questions. Real medicine checks what happens outside the clinic. Real medicine respects aging physiology instead of pretending that every body responds the same way. So what should you actually ask your doctor if you're over 60 and trying to figure out your real target? Ask this: based on my age, my health conditions, my medications, and my symptoms, what blood pressure range is safest for me? Ask, should I check seated and standing pressures? Ask, what home average do you want me aiming for? Ask, am I being treated to reduce long-term risk while still protecting balance, energy, and kidney function? Those questions are far more valuable than asking, why am I not exactly 120/80? Because now you're entering a smarter conversation. You are no longer begging for a number. You are collaborating on a strategy, and strategies save lives better than slogans ever will. Let's go one step further, because I know some of you are wondering what a calm, practical home routine should look like. It should look boring. That's how you know it's good. Same times, proper rest, proper cuff size, feet on the floor, arms supported, no talking, no panic, record the numbers, notice patterns, notice symptoms, measure the way your doctor instructed, not every time anxiety whispers in your ear. The best routine is not the one that generates the most readings. It is the one that produces the most trustworthy information. And then, once you have that information, you bring it to your clinician and decide together whether your current range is protecting you or whether it is time to adjust carefully. Calm routines produce clear data. Clear data produces safer decisions. Now let me tell you something I wish every family member understood. When an older parent says, I feel dizzy but my blood pressure is perfect, do not stop listening at the word perfect. Ask what perfect means. Ask what the actual numbers are. Ask whether the dizziness happens after standing. Ask whether medications recently changed. Ask whether meals were skipped, fluids were low, or multiple readings were taken in a row after anxiety built. Because family members are often the first ones to notice that a senior is moving slower, gripping furniture, sitting down more often, or becoming afraid of stairs. Those changes may be brushed off as aging, but sometimes they are the shadow cast by overtreatment. A safer blood pressure target can preserve not only health, but confidence, movement, and independence. I also want to speak to the seniors who have spent years feeling defeated because they could never quite hit 120/80. I need you to hear me clearly. A reading above that number is not proof that you have failed. It is not proof that your body is broken. It is not proof that your treatment is worthless. Blood pressure control is about risk reduction over time, not cosmetic perfection in one moment. If your doctor has you in a range that makes sense for your health, if your home averages are acceptable, if your symptoms are absent or minimal, and if your treatment is protecting rather than punishing you, you may be doing much better than you think. Please stop letting an oversimplified myth steal the reassurance that well-managed care should give you. And to the seniors who feel proud because their numbers are very low, let me say this with love and with caution. Low is not automatically better. Low can be wonderful in one person and risky in another. If you feel strong, clear-headed, steady, and your doctor agrees the range is right for you, that's excellent. But if the price of those low readings is fatigue, confusion, wooziness, weakness, or fear of standing up too quickly, then the situation deserves attention. The body pays the bill for every treatment decision. Never forget that. Good medicine is not impressed by numbers alone. Good medicine asks whether your heart is protected, yes, but also whether your brain is alert, your kidneys are safe, your balance is intact, and your life still feels livable. So here is the truth I promised at the beginning, the truth hidden behind the biggest myth. The best blood pressure for older adults is not a universal 120/80. The best blood pressure is the range that lowers your risk of stroke, heart failure, kidney damage, and vascular decline while still allowing you to stand safely, think clearly, walk steadily, and live independently. For many healthy older adults, getting below 130/80 may be an excellent goal if it is tolerated. For others, the safest target will need more nuance. That is not confusion, that is wisdom. The body you have at 75 or 85 deserves individualized care, not a one-size-fits-all slogan borrowed from a poster and applied without thought. Let me end with Margaret, because her story captures the entire message in one human moment. Margaret was 82 and deeply anxious that her readings were never perfect. She brought me pages of numbers, circles around anything above 120, and a face full of worry. But when we looked carefully, her average home readings were solid. She had no dangerous symptoms, and her treatment was doing what it needed to do. The only thing truly harming her was the belief that if she was not at 120/80, she was somehow unsafe. When that myth was finally lifted, you could see her shoulders drop. The fear loosened. She stopped chasing perfection and started protecting her health. That is what I want for you. Not obsession, not panic, not number worship, clarity, safety, confidence. If this video helped you see your blood pressure in a completely new light, share it with another senior, a spouse, a sibling, a parent, or a friend who still believes 120/80 is the only number that counts. And please remember this final line, because it may be the most important sentence in this entire video. Don't chase the prettiest reading. Chase the safest range for your body. That one shift in thinking can prevent overtreatment, reduce fear, improve conversations with your doctor, and protect your independence for years to come. Take care of yourself, keep measuring wisely, never change medication without speaking to your clinician, and I'll see you in the next video.